Okay, let's get started so we can stay on task. We have so many more really exciting talks to hear. So our next speaker is Larissa Heideman. She says that I'm probably butchering it, but it's okay, Heideman, from the Netherlands, who is going to talk about automated home-based assessment of dystonia in children with GNAO1 syndrome.
All right. Thank you so much for the invitation. And as one of the newest members of this lovely community, I'm very excited to be presenting our study protocol of one of our projects. And since it's still ongoing, literally just started the inclusions, that's why I'm keeping it as a study protocol. So first of all, even though I know most of you are probably already expert on the topic, just to be sure we're all on the same page, dystonia is a movement disorder that is caused by intermittent or continuous muscle contractions, and it may lead to hyperkinetic, which means excessive movements, and or postural changes. And as you all know, is that different parts of the body can be affected, and particularly for children who have GNAO1 related disorder, we know that the dystonia presentation and severity can vary widely amongst children. So that's why, oh, it's blue. That's why our first question, what we're interested in, is how do we assess the severity then? And this has been mentioned already by previous presenters, so that's lovely. So I can keep it short, but currently what we do in practice is that we visually inspect these children and we use clinical rating scales, such as the BFM mentioned before, to classify severity of dystonia. And this can be done using standardized tasks, but that's not always necessarily the case. And it can be done by physicians or other trained healthcare employees. So to kind of understand our thought process behind this project, I think it's good to address some limitations of the way we do things now, even though it's well established, to understand the basis of the project. So just want to highlight a few limitations. First of them being, it is a subjective measure, which means that it's based on my expertise, for instance, as a clinician, which may as well differ from my colleagues. Another thing that's been said before a few times is that sometimes it can be quite time-consuming depending on the clinical scale you use. What we also know in children who have dystonia, so that's also for children who have GNAO1 related dystonia, is that the severity and the way it's presented can vary amongst even within a short period of time. And we know that factors that can contribute to it can be, for instance, fatigue, can be pain, but even emotional stress. Another thing that we've noticed in clinical practice as well is that sometimes, which has been addressed already by Dr. Amy Viehoever, is that sometimes when we try to, let's say, quantify treatment effects, when we use these clinical scales to rate severity, we don't always see a significant improvement after a given treatment. But we do sometimes see this improvement when we use other scales that look at other domains of daily life. So that's why we wanted to find a new measure or one that's already out there, that does a job of looking at it more well-rounded when, for instance, we want to quantify treatment effects, but also look at disease progression. So this leads to the second question, which is what could be some new strategies? And I think it's always to look back to the past when we look at when we want to understand why we can do things better. So I just want to highlight a few studies. So I just cherry-picked them because of the time I have. I'm sorry, it's just going automatically if you're wondering why I keep tapping it. But one study done in 2006 by Sanger et al., he wanted to see if the data that's being collected by, I'm just going to pause it, if the data is collected by wearable sensors when looking at dystonic movements in children who have dystonia due to cerebral palsy, which is a different cause for dystonia. He wanted to see if the wearable sensors do a similar job in looking at and tracking dystonic movements. And just to put it a little bit bluntly, what this graph shows is that when trying to detect dystonic movements, the way that we look at dystonia and severity of dystonia by using a clinical scale, there seems to be a relation between the data collected by and picked up therefore by wearable sensors and the way that we classify and rate severity of dystonia. When we go a little bit more in time, and this is a study done by a former colleague of ours, he wanted to see if we could go a little bit further and not only look at the data collected by wearable sensors, but also at video data, so videos recorded by parents or caregivers. And he wanted to see if we put this all in a computer model that tries to predict severity of dystonia based on the way that we classify the severity of dystonia, if this model could actually accurately predict this. So this is kind of the basis for the recreation of our project, and we wanted to do a little bit more, but I'll get to that, what that actually means. And another thing, aside from trying to automate these assessments, because we're clinicians, we also want to see if it's actually feasible, because we ask a lot of caregivers to do this for us. So first of all, some basics. So what's the concept? How do we do this? We include children who have GNAO1 dystonia, but we're also including children who are typically developing, because we're interested in not only studying dystonic movements, but also non-dystonic movements to distinguish this accurately. We ask them to perform standardized tasks, which allows for us to clinically rate them. And we ask them to do this using a mobile application called the Modus at Home app. If you're interested in it, you can scan the QR code. It's actually an application we've developed at our movement laboratory. And the reason why we ask them to use this mobile application is because it allows for the collection of time-synchronized sensor and video data. And at the end, we ask them to also fill in a short survey so that we can assess feasibility. And we ask them to do this, the task at least once a day. And once they're done performing the task, we ask the caregivers to let the child wear the wearable sensors and just go around about their day as they usually would, so that we can also study their normal day-to-day movement. For now, it's a minimum of 5 days. We ask them to do this. It doesn't have to be consecutively. We do this, we discuss this with the parent while planning this. So then we get all this data, and what do we actually do with this? So this is the part where I'm going to discuss a little bit more the thing we want to do a little bit more than our colleagues did. So instead of just feeding the model all this data, we want to try and define this better by extracting features, so clinical features based on clinical characteristics we look for when we try to classify severity as dystonia. So for instance, this is a stick figure, which is a metric you can use to, let's say if you want to say something about the head deviation, you can look at the body angles, and you can say something about the amount of deviation there is. Another thing when you're looking at the sensor data is you can extract different features, and there's already been addressed a few by Dr. Villevert as well. But let's say you want to say something about dystonic movements, you can extract a feature called smoothness, which tells us something about literally the smoothness of a movement. The same can be done for if you want to calculate dystonic tremor. So all these features we will calculate using specific metrics, and this will be fed into the computer model. So then the model has all this data, but it actually needs to understand what the data means and what to look for when it needs to classify severity of dystonia. So that's where we need a reference for. And to this day, our golden standard is the use of clinical rating scales. And for us, that's these two clinical rating scales. So we as healthcare employees will then rate the videos using these scales. And then the scores will be fed into the model so that the computer model knows what to look for and how to classify severity of dystonia. So as I said in the beginning, because dystonia in children who have GNAO1 related dystonia, it can be very heterogeneous the way it presents. We therefore create prediction models for each child separately, because at this point in time, we're not at a stage yet where we feel like we can create general models for all the children, meaning you only use one model to classify every child. So back to clinical care, because why does it matter? I mean, it's interesting to me and to us as researchers, but what can be said for you? I think it's interesting because we're trying to refine a measure that's been known already, which also captured more than just the motor aspects that the clinical rating skills does. We also look at aspects of daily life and quality of life indirectly, and we hope that by refining this measure, we're ultimately optimizing treatment strategy and are better equipped to quantify, let's say, treatment effects over the course of time more optimally. And then also, I call it real life, real time data, but it's interesting because we're also, sometimes in clinics we only have a snapshot, so a short moment of time to look at children and assess them. And as you as parents may know, is that in a different environment, their dystonia can be different. So we hope by collecting this data, we get a more better representative image of dystonia and severity for each child independently. So I hope you could follow it, even though my slides were having their own blast. And I just want to give a big thanks to my supervisors. Oh, that's the next one, sorry. To my supervisors and all the partners and collaborators on this project. Thank you.
So that was a great talk. I could definitely see, the value in having patients wear that for the week before their clinic appointment and showing up, and the data comes and you can make your own assessment, and combining that as being helpful. Have you been using that clinically yet to help you?
Yeah, good question. So the project before me was a proof of concept, so just to try without standardized tasks to see if it's actually helpful in clinic. At this point, we're not using it because I'm using it for my project. But before that, we have tried it in clinics, and the families have found it very a nice contribution to the care, because they feel as if they can, give more information than just by literally explaining what they've seen over the course of time. And also caregivers find it very nice because then they can look at the videos and actually get a good idea of how dystonia presented itself over the course of time, so to evaluate.
Yeah, I can imagine it gives them the language to understand what you see from your expertise, but to help explain. Yeah.
Exactly.
Other questions? Yeah. Oh, Amy.
Yeah. Oh, hey. So, how did you? Maybe I missed this when you were going through the slides, but how do you set up the video such that it gets quality and you can see all of the joints?
Yeah, good question. So, looking at the previous studies that's been done by my colleagues, I, for my task, very precisely described just for now how to position the camera. But then again, because I asked them to do different tasks, if only a part of the body is displayed when they're doing, let's say, like a grasp an object project task, it's all right if I don't see the joints, because I also include other tasks to do that. So I still have enough data to feed my model in the end.
Okay. But the video part is just kind of separate, and then when they're going about their day, you don't have the video, right? Or
yeah,
okay.
The video part is just for now to train the model.
Right. Okay. And so there's, at the beginning you have them do a certain number of tasks,
Yeah.
and then got it.
With the sensors, yes. Thank you.
Thank you very much for your study. I just was interested, my son's 23 with a severe cerebral palsy. He's having 3 monthly Botox. Is Botox considered any in the study? Are some of the children having Botox?
So at this point, we don't really make a distinguishment between what kind of treatment they have. So we take it into consideration. But it will be interesting to see if we can pick up subtle changes when they do get treatment. So for sure, that's something for the future. But for now, we don't really take that into consideration. Thank you.
Hi. So just as a parent, this is really interesting because when I observe these movements in my son, we as a parents have to distinguish, this is dystonia with chorea, or this is just dystonia, or is it just chorea? Because it looks like, and like, this is my experience, right? For whatever you had that video where it was flexors with dystonia and chorea, like this type of medication works. And yet if it's just chorea, then something else works. So for parents, like, I realize, at least in my case, I have to distinguish it and say, oh, this is that type of movement, so it only, then this works. And so it'd be I'm super curious how this pans out, and if we could in US take part in this study.
Well, I'd love to. And thank you. I'm very happy you addressed that, because that's also one of my interests is, especially I literally graduated last year as a physician. So when you study movement disorders, you study all these definitions, and then you go into clinical care and you're like, this is dystonia and this isn't chorea. So I hope as well that we collect now a lot of data, so I'm very aware of that. We're asking a lot of caregivers and parents of just families in general right now, but this allows us to further study movements in children as well and see if we can maybe find features that can distinguish chorea for dystonia in the future as well. So yeah, thank you for that contribution.
I just had a question as to, is the intention that over time the child will be able to wear the accelerometer without the video?
Yeah.
Okay.
Yeah. So this a similar project has been done in the field of adult neurology. So that's where I gained my experience mainly from, where they validated a particular app for them Parkinson's disease. It's a bigger group, so it's easier to do that. And eventually, what it does is then these prediction models are they learn just as you and I do, and so they're able to pick it up just by looking at the movements, or maybe not even like the features I tell them to look at, but then they learn other things to look at. So eventually, that's my aim. Yeah.
All right. Thank you, Dr. Heideman.
Thanks.